Oh, hey, Chris.
Hey Chuck, how are you?
I'm fantastic. How are you?
I am doing well. I'm excited. We're going to talk about something that is near and dear to your heart today. So that's going to be great.
Right. Well, the people have spoken, and it is clear that they like sports podcasts the best. And a distant second is Nerve. No one has ever clamored for Congenital, and it's been hard for me to keep my lips sealed on one of my passions.
So tell me why you think that is. Do you think it's just very niche? Do you think it's just are they intimidated by the kid part of it, the genetics part of it? Tell me why this is an important thing I should at least know.
Well, I believe that every hand surgeon and trainee and therapist should understand kids. I think there's many reasons. One, there are technical pearls that are procedures done routinely in the pediatric population that translate nicely to the adult population, so comfort level can be built. Um, Interacting with kids and families is an acquired skill that I'm still acquiring. And I think that's incredibly valuable. And thinking about how to get the best out of surgical outcomes with kids, whether that be through therapy or just working with the family, is also an important skill. And so on the surface, some might think that it's time spent maybe in a congenital OR situation that could be better spent elsewhere. I couldn't more strongly disagree. I think there are many lessons to learn in the OR, and I think there are certainly congenital cases that all hand surgeons should consider, and there's other congenital cases that most hand surgeons should not consider. So I just spouted off a lot, but what resonated?
So, well, we talked about it a couple of weeks back when we were doing our fellowship interview episode about how there is value in learning congenital, but you obviously, if you're not going to do it, you may not want it to weigh too heavily on your schedule for a very limited and already dense year. How do you conceptualize the learning important principles about congenital hand surgery, but also for you, I also know that you guys don't really love it when people dabble in congenital. So if somebody's going to learn this stuff in fellowship, uh, do you just want them taking the principles away, or do you actually want them doing some of this stuff when they go out into practice?
Yeah, a lot to unpack. So first of all, I would say that it's a relatively saturated market, meaning there are hand surgeons at almost every single children's hospital in America, where that did not used to be the case. So lots of hand surgeons specializing in peds. Um, and so to build a congenital practice is not necessarily the goal. So Lindley Wall and I made a choice years ago not to have a separate congenital fellowship. There are a few of those in the country, and I'll tell you, many of those fellowship leaders wonder whether it's the right thing to do because there's simply not a lot of job opportunities. But I think a principle-based learning of congenital is important. It's important for the history of hand surgery in general. And as I mentioned before, that there are technical things that we learn and see regularly in peds and in kids with birth differences that you just don't see in adults very often. And when you see them and you're experienced in the treatment, it's just much easier.
So let's start a little series. I know this is going to keep you engaged in the podcast for the rest of the season at least. Let's start a little series, congenital hand surgery for the non-congenital hand surgeon. So teach me some of these principles. Can you pick a condition that you'd want to start with? And we'll just go from the very basics and kind of tell me what I should know or what I should appreciate.
Well, I think most simplistically is in I keep saying pediatric. I probably should be saying congenital, but in pediatric or congenital hand surgery, this non-traumatic, one of the things we do all the time is lengthen skin. And the basic reason for that is if I treat a kid at a young age, whether I'm the world's greatest surgeon or not, I will create a scar, and that scar will not lengthen as rapidly as the bone will grow. And so scar contractures are common. And so Z-plasties and soft tissue rearrangement are a frequent part of our practice. And I'm not solving those issues with free flaps or massive flaps. It's typically Z-plasties, as I mentioned, or small random flaps that are really vital and we do all the time. In the adult world, I don't do that very often. Do you?
Well, sometimes you have to do a Z-plasty, and then you'd rather know how to do it before you need to do it. The time that it comes up for me is, after a trauma, a massive crush injury to the hand, but then also potentially after a Dupuytren's release.
Absolutely. That's exactly right. And not the hardest concepts or, procedures that we do, but just the basics are so fundamental to peds and so important for a trainee to understand before embarking on their career, even if they don't take care of kids. So that's the low-hanging fruit. That's the super easy part.
Well, what's a Z-plasty?
A Z-plasty is a way to lengthen a linear scar, and I am not a plastic surgeon, full disclosure. And most classically, I do one of 3 Z-plasties. So the easiest is the 2-flap 60-degree Z-plasty, which lengthens by 75% that band. When we're performing a Z-plasty of whatever variety, not only are you rearranging the skin, there's inevitably a scar tissue band beneath the skin, which you excise. But a 2-flap's the easiest. 4-flap Z-plasties can be managed in a couple different ways, but it gives you a nice lengthening of the soft tissues, but a less acute depth, so to speak, of the site of lengthening. So if you're doing in the first web space, for example, it may create a nicer, softer closure rather than the acuity of a 2-flap Z-plasty. And then sometimes I do a 5-flap Z-plasty, which has different cute names like running man or jumping man, but 5-flap just adds a V to Y plasty in the middle of your 4-flap Z-plasty. So those are the ones I use regularly. I do use them in Dupuytren's on occasion, but mainly for me, it's the pediatric population.
Now, are you the kind of surgeon that's going to draw out your Z's before you make your excision of the prior scar, or are you the kind of surgeon that's going to, excise the scar and then figure it out afterwards? I've noticed that there are some differences among plastic surgeons and orthopedic surgeons with how you approach that.
I think you said that right. There are definitely differences between how a plastic surgeon and an orthopedic surgeon handles things. I will say, if we're considering a diagnosis like radial polydactyly, I excise the extra thumb, then figure out how to close it without a linear scar. But when I'm doing Z-plasties, I take the opposite approach. I meticulously plan out my Z-plasty. I often measure to make sure each of the limbs is of the same length, and I try to shoot for 60 degrees. I don't pull out the goniometer in the OR, but I'm pretty anal retentive about getting that right.
I was going to ask you if you had the sterile goniometer, because I feel like that seems to be a very Chuck Goldfarb-ish kind of thing.
We do have one. I don't always use it at the shrine.
Okay, got it. All right. Well, so let's talk about radial polydactyly. That you mentioned that as one condition that you treat, and that seems to be a relatively common and perhaps straightforward congenital condition. So tell me what that is.
So how many hours do you have? So it's interesting. When treatment of radial polydactyly was first described, maybe 60, 70 years ago, they just talked about taking off the extra thumb. And for most radial polydactylies, that's not good enough. Increasingly, and there's actually 2 papers in the literature this year that have modified the main classification. The main classification in the literature is called the Wassel classification. And many of us now choose to call it the Wassel flat classification, because the lore is that Dr. Wassel was a fellow under Dr. Flat and looked up his patients and wrote a paper and did not include Dr. Flat as an author. I think we've even talked about that in the past. And so most of us call it the Wassel flat classification, but there have been 2 articles in the last year in different journals that have suggested adding a hypoplastic category to the Wassel classification, with the implication that you can then just take off that thumb. Every hand surgeon in America would be comfortable doing that as long as they have an opportunity to operate on young kids, because that surgery can be done at 6 months of age or something like that. If it's more than a little hypoplastic thumb, that's a real extra thumb, then I think most of them, I would think, would benefit from the precision and the kind of experience of a congenital hand surgeon. But the
How
base,
much bone do you need to make it a real thumb that somebody like you needs to take off versus somebody like me? And no, I'm not trying to do any congenital, but how much of a thumb does that take?
I think fundamentally you have to have essentially a normal thumb with a very small thumb attached to it. Whereas the thumbs that require more precision in their reconstruction are two smaller thumbs that may be well aligned or may have angular deformity through the bone or through the joint. But if it's truly an extra hypoplastic thumb, then it's pretty obvious that the main thumb is pretty darn normal, and then the extra thumb is pretty small.
So how do you how how do you take off the extra thumb? If you're just taking off the small, if you have a normal thumb and you got a smaller little guy next to it, what do? You just take a little rubber band and wrap it around and squeeze it real tight?
That's for the extra pinkies in the
Okay.
newborn nursery. For the thumb, we probably don't do that. They're not quite so hypoplastic. Just a little elliptical incision. There's usually a single nerve and a single artery, and you cauterize those. You don't want a little neuroma forming if you can help it subcutaneously. But it's a 30-minute operation. The exciting coding dilemma for hand surgeons like me in the OR is if you really are just taking off that extra digit, do you bill for a very small procedure like CPT 11200, or is it a reconstruction of a polydactylous digit, even though all you did was lop off the extra thumb? So a little tricky and a little interesting. But the more complicated radial polydactylies there's a huge variety of them, which has made reporting difficult.
So what are the things that you teach our residents and fellows about kind of the more complex radial polydactyly cases that they could potentially take into the future?
Yeah, I think the first thing is when you close, you don't want a linear scar, because in a child, a linear scar in the wrong place will lead to a scar contracture over time. And so, as I was joking earlier, orthopedic surgeons take off the extra thumb and then figure out how to close. Well, that figuring out how to close always includes like a V to Y plasty of some sort. That's the most simple message. But if you think about an adult hand surgeon who may be occasionally performing a ray resection or some type of bigger reconstructive surgery of the hand, understanding racket incisions for exposure, so circumferential incisions that then lead to identification of the neurovascular bundles, the collateral ligaments, and exposure of the joint. Those are principles that are easily learned and taught in the congenital space and are so uncommon in the adult space that without that congenital experience, I think it's just harder to get them down.
So when you talk about a racket incision, so I remember making a racket incision for some ray resections. What are the pros with that in terms of how do you size that? How you think is should you just always go bigger because you can always trim it down later? Where should the kind of the larger part of the racket be as opposed to the handle? That kind of stuff.
Yeah. So, if you're doing a racket incision for a ray resection, for me, the key is you want to adjust that racket incision so that you can, when you close, you can recreate the web between whatever digit is radial and whatever digit is ulnar to the ray that you excise. So if you're excising the ring finger, you have to think about your closure such that you have recreated a nice web space. The thumb is easier because it's just the thumb. And clearly you don't want to be left with a shortage of skin. And again, in the orthopedic way, we save more skin and then trim the skin at the end. The classic plastic surgery way of doing this would be a racket incision with a kind of fillet flap zigzag incisions on each digit that then meet perfectly after the extra digit is excised. The other, go ahead.
No, please go ahead.
Yeah, I mean, as I think about the next most common congenital condition that non-congenital hand surgeons might consider would be syndactyly. And I'll say this: I don't think there are many orthopedic hand surgeons that are looking to do syndactyly cases. I'm guessing that most of the non-congenital hand surgeon procedures like syndactyly are done by plastic surgeons who feel very comfortable with soft tissue handling. And I think that's fine. Some syndactyles are more straightforward than others. Complex syndactyles where there's bony union, it makes it more difficult, and the results are always less satisfying. But my thoughts are, the surgeon has to have the knowledge and expertise, which I think many can have. You got to have a great therapist to help manage the soft tissues after the procedure's over, and you got to have a system set up for these kids. It's more than just the surgeon expertise to get the best outcome.
So when what you said, not all syndactyles are created the same. So what are the different types of syndactyles, and what are the ones that should make us a little more worried versus the ones that can be handled by somebody with little experience in this?
I would say the syndactyles that are not super tight together, so the fused fingers where there's a fair amount of skin between the fingers makes it more easy. When there's no bony connection between the phalanges, makes it more straightforward. And I would also say when there's not an associated syndromic condition, because those kids do more poorly in general. And I think the reconstruction has to be more cognizant of the general health of the child. And so I think an isolated, classically middle ring finger, partial or complete syndactyly with lots of extra skin between the digits can be pretty straightforward to handle. But most syndactyles also need extra skin. So then you're thinking skin graft, or you're thinking skin graft substitute. And so it can get tricky pretty easily. And so, for example, when I see syndactyles treated in the community that come in with a groin skin graft in 2022, there's nothing wrong with it, but I don't think it's up to date. I really don't. The skin darkens. If it's not taken laterally enough, it's hair-bearing skin. And there's just easier ways to do it in 2022. And I think most congenital hand surgeons for a simple syndactyly would not use groin skin.
So what is the right skin to use?
If you choose to use a skin graft, most people use antecubital crease skin. Some will use skin along the transverse incisions near the wrist crease. Again, it's not wrong, but I'm just not sure it's right to use groin skin because the color match and the hair bearing issues are real. I tend to use skin graft substitute. So I use Hylo Matrix, which has been really successful in our practice. So it's kind of like Integra. But in kids young enough, the epidermis can reform over the skin deficit area very nicely. And so we've been using that. And so it decreases the need for a second incision in the harvest site.
So as we bring this first episode of Congenital for non-congenital surgeons.
First and maybe last.
Well, what are the things what are the conditions in brief that you think that are treated in, quote, the community that probably should be treated by somebody like you? And what are the conditions that are sent in that probably should be treated, by a competently trained hand surgeon?
Yeah, it's the right question. It's not such a simple question because, again, if a community hand surgeon has the expertise, the interest, and the systems, which includes a great therapist in place, then this can, then that's very different from a hand surgeon who has done a little bit of this as a resident, doesn't do things regularly, doesn't have a therapist they work closely with. That's harder. But the right kind of post-axial polydactyly or little finger polydactylies are typically much more straightforward. As we mentioned, the radial polydactyly where the extra thumb is truly hypoplastic, that's pretty straightforward. The straightforward syndactylies. One diagnosis which could easily get grouped here is congenital, which is a misnomer, but really pediatric trigger thumb. So a trigger thumb there's nothing complex about treating a trigger thumb. The questions are about safety of anesthesia and timing of release and how long you watch it before you do it. But pediatric trigger thumb is quite common and quite straightforward. Those are the ones that immediately come to mind. When you get to things like radial deficiencies, hypoplastic thumbs, cleft hands, symbrachydactylies, those carry a little more complexity, at least in my mind. And it's not only the technical skills, it's the decision-making process, the family counseling, the associated geneticist. There's just so many variables that either you have a system in place or you don't. And, why fight that fight if it's not easy for you and your system?
So what is the right timing for trigger thumb surgery and the type of anesthetic that should be used for trigger thumb surgery?
There was a good paper this year by Doug Hutchison and others from Salt Lake City, which looked at a large number of trigger fingers. And Doug decided that he was tired of treating trigger fingers, so he wanted to watch and see what happened. So he tried to assess natural history. And basically, the conclusion was if the trigger is contracted at more than 30 degrees, and if it's bilateral, it's unlikely to resolve. And going ahead and doing the trigger thumb after 6 months or whatever is totally fine. A less notable trigger finger, a unilateral trigger finger or trigger thumb, has a chance to resolve. And if the family's not interested in just the simplicity of a trigger release, then going ahead and watching it is fine. In the United States, it's just so simple to take care of this, and you see them once after surgery and the kid's done, that most of us offer trigger releases after 3 to 6 months of non-operative care. Let me flip this around.
Can I ask one more question about the trigger thumb?
Yeah.
I feel like there's a couple more things on. I don't ever think we're going to talk about pediatric trigger thumb ever again on this show. So,
definitely not.
Well, so is the non-operative treatment, is it observation or is it splinting?
It's just observation, because you can't effectively treat that age kid with a splint. And so some would say stretch and some would say splint. That doesn't work. It's just observation.
And then in terms of the timing of surgery, what's the safe age for anesthesia in this particular case? And then what kind of anesthesia is it?
Yeah, usually, there's been a lot of literature and there was a lot of discussion a few years back around safety of anesthesia in the patient younger than 3 years of age. I think that really applies for prolonged or repetitive anesthetic exposures, but a 2-minute exposure for a trigger thumb, I don't think is a big deal. And typically it's a masked anesthesia. We do tend to give some Marcaine before the surgery starts. That's been proven to decrease the amount of anesthesia required. And at most it's a 5-minute surgery. So very simple surgery, very short anesthesia, and then rapid recovery.
Now that the digital nerves to the thumb are quite small, even in adults at times, how much more worried are you about that in a kid?
No worry. The goal is simply stay midline, stay right over the A1 pulley, release the A1 pulley. And a locked trigger thumb is easy to release because you essentially start proximally and your release is done when the thumb straightens. And so you don't need to I don't plan to and ever attempt to visualize the digital bundles. I just stay directly over the flexor tendon sheath. So flipping this around, what nerve surgeries should not be performed by people like me?
I think, how much time do you have? I feel like that's an episode in and of itself.
That probably is.
We should have that episode, and it can, I think that nerve, I think it can be done very well by a competently trained hand surgeon, as long as you've done it in training. And there are a lot of things that I have learned to do since finishing training, just based on principles and practice and going in the lab and all that kind of stuff. I think the things to think about are, if it doesn't work, can you take care of the issues down the line? For example, so say like an upper trunk plexus. If you do an Oberlin or a double fascicular or double Oberlin nerve transfer and it works, it's fantastic. It's one of the most gratifying surgeries we have in peripheral nerve. But if you have indicated the wrong patient and then you have now taken that option from me because perhaps it wasn't just an upper trunk, and perhaps you've now used a donor nerve that I can't use for something else, or there's just, when it works out great, it works out great. But it's more about making sure that you have a sound foundation in terms of the diagnosis, the treatment options, and then knowing what the options are should it fail. And not that we ever plan for things to fail, but that's reality. You need to know your backup options. I think that's one example of, if you've been trained well, you're up on the current indications, go for it. But if there's any doubt or any hesitation, that probably should be sent somewhere else. Not because the technical parts of the surgery are that hard. It can be a very straightforward surgery that is very fun to do, but more because of all the other considerations that come around it, like you were describing.
Yeah, it's interesting. I mean, when I think about things like radial deficiency and I think about upper trunk plexus, why would a kind of community hand surgeon, there's no offense intended by that label or by what I'm about to say. Why would they want to treat these two conditions? And maybe it's because they're in a rural community and they're, the patient wants to stay local and have that treatment. But there's just a lot of complexity, sometimes with the technical aspect of it, sometimes with the follow-up, as you said, sometimes with the necessary team approach to both of those conditions as examples.
Yeah, and I think that, but there's a real argument to say for some conditions, why send somebody into another center 3 or 4 hours away if they can be cared for locally. And especially, you're seeing little ripples of that as, when we've gone through waves of, bed crunches and stuff, not for this kind of stuff, but, for anything that would be inpatient, admissions and stuff. I think we tend to be a little more willing to see patients from elsewhere because we want to be helpful, but there are probably times where patients could stay locally, but nobody wants to err on the side of not accepting a referral just because you think it can be treated locally, because you don't know the circumstances locally.
Right. No, that's exactly right. I think this is a sensitive conversation, and I'm sure that my comments may have annoyed some listeners. I hope if I do annoy you, one, that you don't stop listening, but two, that you write in and let us know your thoughts, because we would appreciate that.
Hashtag cancel Chuck is what we're going for here. So, Chuck, I think.
Go ahead.
I think I know your win for the week. It's probably getting us to talk about congenital on the podcast, but do you have a win for the week?
Well, that is a huge win. That's exactly right. My win for the week is in the middle of COVID and in the middle of Snowmageddon St. Louis 2022. I was 11 for 11 for my main surgical day, not a cancellation.
Wow.
How did that
That's
happen?
Huge. That hasn't been the case in recent weeks, has it?
No, I feel like we're on the downslide. What about you?
Okay, good. I will say my win for the week was walking into a case recently and surprisingly seeing a fellow who could take the resident through a case. So it was great. I walked in, I was like, oh, my day just changed a little bit. My morning's a little different now. I can relax a little bit more. So that was a huge win for me. We have a program that oftentimes does not have residents and fellows scrubbing together, except if it's, somebody's out of town or something like that. But it was very nice to allow our fellow to really directly supervise and walk a resident through a case. That was wonderful. And I did my normal thing. I kind of stayed in the room and supervised and heckled and provided encouragement, not heckling, and some pointed feedback.
It's an interesting time of the year, because certainly at this time of the year, fellows have been around for 6 months. They know they know a lot about how we do things and what we're doing. It's also the time of year where fellows get a little antsy and they're thinking about next year. So keeping them engaged in different ways is both helpful and productive for all sides.
Agreed. Well, you have a wonderful rest of your day and enjoy the rest of Snowmageddon.
Thank you. Take care.
Bye.